But what you just did was massive for those patients like myself that have been out there and have felt lost. And that is that you've given them permission to put together a team of people that study cardiology and neurology and immunology to get them out of the dark place they're in. They don't have to feel like they need to suffer alone, that they need to pull in the data that they've collected by self-reporting effectively and by continuing to ask and ask and ask for care until you receive the care you deserve. Hi, I'm Haylie Pomroy. I am the Assistant Director of the Integrative Medicine Program here at the Institute for Neuro-Immune Medicine. It is our goal, our charge to bring you hope and help, those of you that are dealing with fatigue and chronic illness. And today we're covering a very hot topic. We're going to be talking about POTS. I am so honored that I have an expert in the field of helping patients dealing with these kinds of disorders. I have Irina Rozenfeld back with us today. Dr. Rozenfeld is a doctor of nursing at the Institute for Neuro-Immune Medicine here at Nova Southeastern University. Dr. Rozenfeld and I have had the joy and pleasure of doing some co-lecturing recently. We are constantly talking about you guys and how we can help. And this subject is actually the number one thing trending on TikTok and health and wellness. It is starting to be podcast about. And what we wanted to do is talk to you about POTS, what it looks like, what's going on in the body. And I had to bring an expert in for this conversation. So Dr. Rozenfeld, thank you so much for being here with me today. Everybody really needs this.
Thank you, Haylie. I'm happy to be back and having a conversation to help patients to learn about their condition and find resolution faster. The more we talk in, the better patient chance to find right clinicians. As a nurse practitioner, I kind of very like to be very much in touch with my patient and help all the way to resolution. And POTS, I was driving to podcast today, was thinking, you and me both like to cook.
Yes.
And we're going to be talking about pots, but not the cooking pots.
Not pots and pans. No, which is perfect. Tell us, define for me, what is POTS? What does that stand for?
Okay. POTS stand for Postural Orthostatic Tachycardia Syndrome. But it's not so simple. So
wait, I'm going to just say that one more time. Postural.
Orthostatic Tachycardia Syndrome.
Orthostatic Tachycardic Syndrome. Thank you. I like POTS.
So syndrome means that there is many different symptoms.
Okay.
And practically POTS, it's not only diagnosis, which with patients who have symptoms and think that we have this illness, we may not really have POTS, and there is a different subtypes, phenotypes. We call this particular group of patients, we have different phenotypes.
So you mean different?
I will explain.
Okay.
Postural orthostatic tachycardia syndrome, this patient, when they standing up, when in upright position, their heart rate elevate, and according to clinical description, it's elevated up to 30 beats per minute. And in teens, it's elevated up to 40 beats per minute.
So they take the heart rate laying down or just sitting down?
No, we will talk about that. Okay. But in this particular case, when patient change position to upright and stay in this position, the heart rate go up by 30 beats. But I actually, as a clinician, I don't really stick to these guidelines because my goal to control symptoms. And what you're going to do is go up 25 beats per minute and not 30.
Or 27 and not 30,
you still need to pay attention. And I want to right away highlight that there is a POTS when tachycardia is a problem. But some patient will have another type, and it's neurally mediated hypertension.
I'm going to dissect the word for a second. So postural is a change in position, laying down, sitting down, standing up. Okay. And then orthostatic, what does that mean?
It's postural, it's a change into orthostatic with It's depend of the where you standing down or you lying
Okay,
down.
so
I guess we should go to glossary.
but orthostatic. So that's like we call it a hormetic event. It's a change in what you're doing, right? So it's a change in sitting or standing or laying.
Orthostatic, it really means going up.
Going up.
Standing
Okay.
or sitting.
Okay.
And sometimes in this patient, we may not standing, we're sitting in front of computer and we're getting these symptoms.
Okay.
And I will explain why.
And with tachycardia, is that the heart rate?
Heart rate.
Okay.
Tachycardia, it's elevated heart rate.
Okay.
Bradycardia, when heart rate slow down.
Okay. And then syndrome means there's many symptoms.
Correct.
Okay. Perfect.
And
Thank you.
we also, this patient, can have symptoms with is a tachycardia, so racing heart, palpitation. And the symptoms this patient will experience, first of all, very often chronic fatigue syndrome, myalgic encephalomyelitis, have symptoms of orthostatic intolerance. Again, you're not tolerant to standing up, to running while you're up, to sitting up for prolonged time. So this is orthostatic intolerance. You're not tolerant to be up.
So does that mean that they start to have an exacerbation in symptoms? Do they have...
Correct.
Okay.
Correct. So with POTS, the symptoms, the palpitation, their frequent heartbeats, patient feel as palpitation, dizziness. Sometimes we discuss with the patient and figure out what we feel. Lightheadedness.
Okay.
Sometimes giddiness.
Sometimes like
shakiness.
Okay. So like
cold
so they
hands.
feel like they have the jitters.
Jitters.
Yes.
Okay. Good.
Yes.
This one.
No, I like that. So
and the cold feet, cold hands. This is variety of the symptoms. The dizziness, when they lie down, they have relief of the symptoms. And shortness of breath, and can be chest pain. It's a variety. I want to mention that we're talking about POTS when it's increase in heart rate. But there is also hypotension. Usually,
so low blood pressure?
Low blood pressure.
Okay.
When patients standing up, the blood pressure dropping.
Okay.
And blood pressure can be monitored, and if it's dropped more than 25 millimeter, then it's points, then it's orthostatic hypotension. And then sometimes patients really need to be standing for at least 10 minutes. They should be standing
Perfect.
up to measure. And it's not necessary. Blood pressure may not drop right away when they're standing up. So physiologically, our body has ability, when we change position from lying down up to upright, the heart rate go up and blood pressure probably dropping, but because of homeostasis and allostasis, hemodynamically, within 30 seconds, we should correct it and stand without dizziness and lightheadedness.
So our bodies should adapt to the simple act of standing up.
Correct.
Changing your posture.
Yes. So in the POTS, heart rate go up. In orthostatic hypotension, blood pressure is dropping. And there is neurally mediated hypertension, there is orthostatic hypertension, there is a little bit different variety. It's really important. I was thinking about that diagnosis is not easy to address. And this is really not for telemedicine, for telehealth.
Yes.
You do need to be
to actually see your patient.
Present and do clinical exam. And in my case, I really like to do this standing test, passive standing. We also call it a NASA lean test. And I ask patient to stand for 10 minutes.
I'm gonna stop just a second because I want to just make sure I understand this. Because so patients are coming in with a diagnosis of POTS or a group of symptoms.
Patient come with chronic fatigue symptoms.
Got it.
Then inside, and right now, chronic fatigue syndrome, categorization of chronic fatigue syndrome, Institute of Medicine, last clinical case description, orthostatic intolerance is a part
of the
syndrome
diagnosis
for chronic fatigue syndrome. And this is how I'm not neurologist and not cardiologist. I'm not actually expert by degree. I'm nurse practitioner who's seen chronic fatigue syndrome with the symptoms of chronic fatigue. And then I see POTS and all kind of variety of orthostatic intolerance and hypotension almost in each patient.
So we've had people come in and in our community talk about that their doctors never heard of the word POTS. Is it a new disease or a new diagnosis?
So description I've can find in literature and lectures from 1940s.
So over 80 years?
It was described as a disease in 80s and 90s, but it still unfortunately didn't make it to their primary care, I guess, to recognize. But prevalence is, this is very common symptoms, very common, and I will explain. And some description goes from 1 million to 3 million people, Americans, can have this illness. I think after coronavirus, after acute viral infection, we see these patients more commonly come in our clinic.
Is it things that we're seeing with patients that have COVID long haulers? We're seeing this?
Yes.
We're seeing
absolutely.
POTS? Okay.
What I want to mention that it's really important that there is many different neurologic and cardiologic conditions which also have POTS symptoms.
Okay.
It can be Parkinson, it can be pheochromocytoma, and I do see patients which we then have to refer immediately to appropriate specialist. It can be seen in multiple sclerosis, it can be seen in Parkinson, it can be seen in endocrinology, in pheochromocytoma. So it's important to recognize there is a POTS as a disease, and there is a symptoms which POTS caused by another condition. I'm going to give you 3 interesting examples which I kind of observe. There is another cause for having POTS symptom is a neuropathy, peripheral neuropathy. It's a neurologic condition.
So people have like numbness in the feet, numbness in the hands,
so
cold hands and feet?
Diabetic neuropathy.
Okay.
And patient with diabetic neuropathy, we're going to have the symptoms of POTS. But you have to treat diabetes.
For sure.
You cannot
Absolutely.
treat POTS. If patient have ulcerative colitis, I have a listen lecture by neurologist, and I really like his example, and I see it in my patient. If patient have ulcerative colitis and it's not controlled, and we're losing fluids, we're gonna develop symptoms of POTS. Because in one more interesting example, anemia. If they're patient anemic, so we have not allowed enough red blood cells and oxygen is not delivered, and we're going to have symptoms of POTS. So you have to treat anemia. So POTS, it's very elusive, but you can rule out all the condition and patients still have these symptoms.
So we're seeing statistically that it's about a 5-to-1 in the female patient to the male patient. Do you think that's because of the complexity of hormones, or why do you think we're seeing that?
It's frequently, right now, I actually see it in the male too, but
Okay.
It's more frequent in female. It's very, very often patient report very acute onset. They know that it was stressful event.
We've seen it.
Very frequently, it's a viral infection, acute viral infection. So the patient kind of report when it started, but occasionally it's also insidious and it starts gradually.
So you'll hear somebody come in and say they either had like a migraine or a fever or a dizzy episode. They get up and they feel like they're going to pass out. Is that, or were they having all these symptoms before and that just exacerbated? Or
honestly, what I see, patient did not really come with the symptoms or complaints that we have POTS. The patient come to our institutes. It's a chronic fatigue. And I really always ask patient I like to do clinical exam, and I ask them take off the shoes and take off the socks. And I want to patient sometimes in front of me first time recognize that there is some discoloration of the feet, which
So
is
like
very
red or purpley or?
red and purple, which is very pathognomic. It's like very significant for this particular condition. And if it's summer and we're in Florida, it's really nice. We always patient walk and we see those
Sandals or flip-flops or
we see discolorated purple feet, and you can look Google and see a lot of pictures of purple feet online. But if you're up north, you may not even see it. And I sometimes ask, did your doctor ask you to take your shoes off? It's interesting, but it's have explanation. So when we talk about what's the cause of POTS, and the first what we really observing is a hemodynamic changes. So it's called hemodynamics, your blood pressure, your heart rate, your...
Okay, hemodynamic changes. So changes in blood pressure, changes in heart rate.
Right.
Okay.
And in a majority of the patients, so there we observe is what making feet look purple. It's a blood pooling. When patients standing up or sitting for prolonged time, their blood pooling to their feet.
Gravity. Gravity's pulling the blood down.
Yes, it's definitely gravity.
Is that why a lot of times we recommend compression socks?
Yes.
Okay.
We're going to come to that.
Okay.
So the pooling of the blood, and great research, Dr. Systrom, he did really good studies and give us really good explanation for chronic fatigue patient syndrome, that we don't have enough blood return to the heart. And the heart doesn't really beat when it's empty, kind of. And so it is, the preload of the heart is low because blood accumulated in low extremities. We see it in chronic fatigue syndrome. The patient with Ehlers-Danlos syndrome, because genetically we have a particular hypermobile Ehlers-Danlos syndrome, those patients with the pooling of the blood in a blood vessel, because we have collagen disease and it's stretchy. So the blood not only pooling in the legs, it also can be in abdomen, in the veins, in the
so
abdomen.
So with people with POTS in general, or with this genetic piece?
That will become... It's a lot of comorbidities. Will be a patient come with chronic fatigue, and we have hypermobility and possibly Ehlers-Danlos and the POTS symptoms.
Okay.
Mast cell activation syndrome is kind of on the top. It's all
works together.
A little bit messy together between all these symptoms.
So if a person's out there, what types of things would they be experiencing? I love the taking your socks and shoes off. Would it have more pooling of the blood when you're walking, when you're laying down?
Sometimes my patient will say, I wake up in the morning and my belly is flat, and then during the day it's all bloating. And they think it's bloating, but it's maybe blood pooling in the legs and the blood pooling in low abdomen. And this is what it's feeling like, it's heavy and bloating.
I want to just go back to that again, if you can, because that is one of the symptoms that so many people will come in and they'll maybe talk even about concerned about food allergies, or they'll talk about, am I allergic to a food or something? And they come in and they say, after I eat, I'm tired and my belly's bloated. And I think they're always thinking that it's enzymes or gut biome, but sometimes it's blood pooling. And that was so fascinating to me.
Very important for this patient. We always recommend small meals. But the talking about blood pooling,
yes,
we recommend compression socks and abdominal binder.
So like one of those, kind of like a waist trainer, like an ACE bandage for your tummy. Yeah. And so is some of that blood pooling causing the fatigue after meals too? Because a lot of people that are ultimately diagnosed with POTS or come in and we have this conversation and we go, we should check the blood pressure and the heart rate because they haven't had it done. It is that they say, I'm so foggy after I eat, and I'm so fatigued after I eat. Is that the vascular component or the mast cell component or all of the above?
It's hard, and I'm saying that as a clinician, you really need to. It can be both. It can be many different reasons. But if patients have POTS, and I kind of like to say it's autonomic dysfunction.
Autonomic dysfunction.
There is a lot of regulation, as I start saying, hemodynamic. So it's a dysregulation. Your body is not regulated properly when you're standing up, and you should reset with your normal blood pressure and heart rate, because it's normally go up. But then in this patient, it's not. And they feel we try exercise, we try to study, we try to walk, and the heart rate goes up, and it's make a lot of, when your heart rate pumping, your heart is palpitations, and you have chest pressure and shortness of breath, feel a lot of anxiety.
Yes.
The heart sends signals, and your brain getting signals. There is a lot of anxiety. So it's correspond with neurotransmitters and hormones going. It's like, I always like immune system, endocrine system, nervous system. We do cooperate or we not cooperate. And this, your body getting this like all signals. There is a panic attack, kind of. So the patient has to get in all these symptoms. When we start unraveling, and with this hypovolemia, possibly this patient doesn't have enough blood volume. And this is why we are having this orthostatic hypotension. We need to replenish volume. We're telling this patient, you need take more fluids. We get in this patient to get more electrolytes. It's hypovolemia can be result of low sodium. It's all pathophysiology, and the pathophysiological mechanism in each patient and each description will be different. For some patients, it will be salt disbalance. For some patients, fluid disbalance. For some patients, will be anxiety and increased norepinephrine. So that is this is why it's
a
not
syndrome.
Simple. It's a syndrome, and etiology very complex. And in each patient, you get in results only if you figure out what is the problem. The usual standard of care, we do have some standard of care, but if you recommend just because for this disease we use this medication, and we just giving this medication because it's standard of care for this disease, it's not necessarily work. We have an arsenal of medication, but we prefer start with non-pharmacological methods, because the patients, when they understand, they don't have knowledge deficit, but they understand what's really happening, and we discuss it together as a group with my patient, then we know what medication needed, and
or nutrition,
very often the patient can adjust lifestyle, adjust exercise. Everything needs adjustment. Then they recover, and they recover pretty well if we caught it on time, and it's a complex treatment, and the patient really participate.
So I want to ask a couple questions. So first of all, it's really underdiagnosed, right?
Yeah, I think so.
It's really underdiagnosed. And I also feel like when we talk about medical gaslighting, or people maybe not being able to articulate what they need from their practitioner. And I love what you said about telehealth. It's really hard to diagnose POTS on a telehealth conversation. I mean, unless you're looking for it and they have maybe some instrumentation at home.
I would not recommend them to do a lot of testing at home, because I'm always afraid you can have syncope or near syncope.
Wait, say that again. You can have what?
Syncope, syncopal episode.
So what that is? Passing out?
Passing out.
Passing out.
Right.
I thought so, but I wanted to make sure.
I'm always afraid to ask patient on the telehealth to do any kind of exercises, stand up and sit down. I'm like,
so let's list. I want to list. So if people are going in and they're getting ready to make their appointment with their physician, what are I see some things consistently with people. What are some of the things that you consistently see that they can express to their practitioner? Look, I would like you to, check me for POTS because I am experiencing what?
most of patients right now have smartphones, can see their heart rate.
Right.
Most of the patient can actually get a little blood pressure machine. And when you wake up in the morning, still in a bed, you can check your heart rate when you're in a bed. And then after you sit up, and 10 minutes after you standing up, you can make your log a little bit for 7 days. I always ask patient to do this 7-day
So log for
for
7
me.
days?
You can come to the clinician with already data,
Good.
with explaining. And from this data, as a clinician, I can see was your blood pressure problem or it was a heart rate problem, because it's a different treatment.
Right. What other symptoms might they have, though? Like, what would make them think that they should be checking this at home?
The heart rate.
Okay, palpitations, elevated heart rate,
it's
exercise fatigue.
It's a racing heart.
Racing heart. I like that.
Heart,
okay.
Dizziness, fatigue, chest pain, shortness of breath. They're cold feet.
Cold feet and hands.
And hands.
Do the hands get pooled blood too? Can the hands be discolored also? Mm-hmm. Okay.
But if it just, some patients and some people, they quite find a way to control the symptoms. The crossing legs when you sitting in this yoga lotus pose.
Yes.
Crossing legs helps shoulders. We actually have a trick. One of my patients, she shoulders in the past, and she said every time she needs to march, or not a march, standing in one direction, she kind of pumping. Exercise your calf muscles.
Yes.
She pumping, and it's prevent from dizziness.
Yes.
So the human body very smart, and sometimes patient doesn't know that, but you walk in the room and a patient sitting on the exam table in a lotus pose.
Exactly. So it's so funny that you said that, because there's this chair that's for sale now, which is the crisscross applesauce chair. Like basically where you're sitting crisscross, they call it crisscross applesauce.
Wow.
Kind of like the lotus pose. And I see so many young adults purchasing this, and they're saying that, when they're in their work environment, that it helps them with, focus. And I always want to check their blood pressure, and I always want to check their heart rate, because I wonder if they're self-medicating, right? If they're trying to keep the blood flow from pooling. I watch that, and I think it's very fascinating.
It's very interesting. I think there is like modality where their patients in their teens, sometimes we see 18 years old, like in their teens they can have this, young teens, they got this illness after being very athletically active.
Yes.
There is no deconditioning there. It was very, very athletically healthy young adult developing this acutely. And there is like 40s, 50s, again after some kind of event. I understand that autonomic dysfunction can be developed after deconditioning, but these patients usually not deconditioned. It's kind of they were very active, and then suddenly they cannot stand up.
Yes.
And they're very weak. They feel sometimes they like paralyzed. They cannot talk. They have a lot of brain fog.
Brain fog. Yes.
Brain fog.
Yeah.
And this is a hemodynamic problem. When your blood is pulling to your legs, if you notice in our clinic, I don't see any other clinic in the country. I don't travel so much, but we have recliners.
Yes.
Because we know that we need our visits long. And we need patients to communicate with us. First, we need to ask questions, and then we have to patient to understand plan. But if a patient will be just sitting in regular chair or just on a physical exam, like in regular practice, within 30 minutes we're losing them.
And the lack of blood flow to the brain, and by lowering, I love that. And when they talk about that, they also talk about when people used to talk about being on the therapist couch. And in therapy, they used to have patients lay down. And a lot of that theory was to keep the blood flow into the brain so that we could nourish the thought, and so that people could process thoughts and process trauma. And when I came into the clinic and I saw the recliners, I thought, that's fascinating. But then, we had talked about keeping the blood flow in the brain during that visit, and the brain fog and the fatigue Is that...
And it's not only in the visit. So this is another part when the non-pharmacological method, when the patient needs they learn to realize that they have to pace all their
themselves.
activities and maybe change way work environment from sitting in front of computer to recline with a laptop and exercise in reclining position and Pilates or some activity, rowing or exercising in a pool. The pool has this water has hydrostatic pressure against your, it's kind of you're wearing compression all over your body because the water pressing.
That's a great point. When we always, or I think it's fascinating, or one of the little flags, and probably just because I'm into talking about food and nutrition all the time, but when a client or a patient comes in and they talk about brain fog after eating, or they talk about feeling lightheaded after eating, large meals, the larger the meal. And like you said, we oftentimes recommend eating smaller meals throughout the day instead of those individuals that maybe don't eat all day and then they have a large meal and then they feel awful. And it's fascinating to me that they a lot of times, again, think about, is it enzymes or is it gut biome? And yes, all of those play a role, but they're forgetting about the blood flow that goes to the GI tract once food is consumed. And we only have so much blood, and if it's pooling in the feet and it's pooling in the tummy, it's not getting enough circulation in the brain.
Other important symptoms this patient may have affect, because this is autonomic nervous system, and autonomic nervous system part of central nervous system, it has two parts, sympathetic and parasympathetic. The disbalance between sympathetic and parasympathetic nervous system. See it simple way, sympathetic is a fight and flight response, and the parasympathetic it's rest and digest.
So in the nervous system, they balance sympathetic.
In simple terms.
So sympathetic is fight and flight, and parasympathetic is rest and digest.
Kind of.
Okay.
Very
basic. Gives us something to hold on to for thought.
Yes, and then if there is imbalance, and usually this patient will have symptoms of constipation, gastroparesis, it's
constipation,
and abnormalities with the sweat and cold temperature regulation.
So temperature regulation, perspiration,
right?
Feeling chilled when it's warm out in the sun,
or maybe not sweating. So this is really, it's not easy, and I don't want anybody self-diagnose, but with a clinician, you have to discuss all these symptoms. It's important.
It's so important to self-report, though. I mean, people are concerned about self-diagnosing, and as a family, we do it, at every dinner table, at every meal. We just have a heyday with it. But I always talk to my family about self-reporting, about really knowing or being in awe of what your body's doing to do this big job of staying alive every day, right? Really being in awe of the body's ability to adapt to all the different stressors, good or bad, and how that nervous system plays that role. In our institute, I mean, we believe you, first of all. We've been in this space for a very long time. So we want everybody to know, we believe you. We understand what you're going through. We want to also give you some pearls of wisdom of things that you can bring to your own practice or practitioner. So I love the concept of logging. I love the concept of being brevity in self-reporting, meaning really isolating what's happening in your body and reporting that in a very articulate way.
It's important, how I want to say that when I have ability with a patient, I really like to find all the different symptoms and control each symptoms. In the parts, orthostatic intolerance, orthostatic hypotension, all these conditions, they're all different and they require different approach a little bit. Thus, one is actually the same for everyone, that we need to replenish fluids. And sometimes it's required maybe 2 and more than 2 liters and up to 4 liters of water.
Is that why sometimes we also do an IV with our patients
So
that come in?
this is what I want to say. Some patients look for IV as a treatment. I do not see IV as a treatment.
Okay.
It's emergency. It's really helps sometimes when this patient in really severe condition and you're giving them IV, it's like IV normal saline.
It's like intervention.
It's intervention.
But they need to hydrate on their own.
It's not sustainable for a prolonged time.
Right.
And it has its own side effects because it will affect electrolyte balance. This patient needs to figure out the way to hydrate, that it's not their IV should be for emergency. When, like in real life, you don't go to emergency room every week.
Right.
So I prefer, sometimes we do IV, maybe for 4 weeks, maybe less, just to help patient to plateau. But there is a condition when patients cannot tolerate fluids by mouth. There is sometimes, then it needs to be IV. But in general, we find the ways to replenish fluids and push fluids through oral fluids, and it must be electrolytes, because the important part when this patient improve on medication which retains sodium, or if we recommend them to take more sodium, particularly the part with low blood pressure patient. But when they retain sodium, the kidney flush potassium out. So this is really important. I always stress and I ask patient to follow up with a primary care doctor or have patient to repeat electrolytes, blood electrolytes, to make sure that when we push in all these fluids, we replenish, we eat potassium-rich food, and we may need supplementation, that electrolytes are normal, because when sodium potassium is not abnormal and then patient come with this big jar, a lot of just water, it may not really, it's really one symptom and give extra new symptoms. So this is really important part of their therapy, that they do replenish electrolytes, we very salt sticks, salt tablets, just food with salt, very helpful to keep blood pressure high, but you have to remember about potassium.
Absolutely. And so just, I always want to say, first we want you to know that it's a very, very real syndrome. We want you to know that it can affect and impact your life significantly. And I think sometimes, like we saw many, many years ago, and still with some people still face a lot of judgment around getting an accurate diagnosis for ME/CFS. There's a lot of people that come in that are just, crying after seeing many practitioners, or struggling because they're finally being heard and understood and looked at. And I think with POTS, I'm so excited that everybody's talking about it right now. I think it's our younger generation that's pushing it to the forefront in the conversation. I think it's, the way media or social media distributes information. There's maybe a lot of misinformation out there, but it's the conversation is happening. So we want to get people in to see their doctors if they're concerned about this. And we want to have them log their blood pressure, their heart rate, and then the variance of that from laying and sitting. Just in general, positive, healthy things. We talked about compression stockings, maybe banding after, or almost
abdominal
like abdominal banding, they call it. But what kinds of things? Like I'm always really conscious when I say, watch that you're not using a water that has a chloride in it, right? That it's not chlorinated in order to get your mineral. Use it in a food source, potassium-rich foods, whole spectrum salts, like a Celtic salt, not just a sodium chloride. Are there other tips that people can do to one, either prevent?
I cannot say about prevention. I will right now. I mentioned at least 5 different etiologic factors. Some people genetically, because of Ehlers-Danlos syndrome, and genetically predisposed to have these symptoms. So when we find out, when we work with the patient, then we develop very personalized plan.
Right.
And there is probably need medication to be. What I want to say that I see improvement, and it may take longer. It can be very short, depending how soon we intervene
Okay. After the episode that caused it to start.
Right. But it takes some time, and the recovery, these patients tend to have good day and bad days, and the exercise, sometimes the physical therapist can be very helpful, but it needs to be very knowledgeable physical therapist in this condition.
But you bring that, I would never have thought about doing physical therapy to heal from POTS, but it makes sense when you say it, but making sure that the physical therapist is cognizant of exercise-based fatigue, pacing, not pushing the body past.
This patient, we do not want you to be, it's a catch-22. If you're not using, you're losing. If you lying down and deconditioning, the autonomic dysfunction only gonna get worse.
Right. We need structure for stability.
If you standing or sitting like 90 degree all the time, you're gonna crash. So this is very, very combination of smart approach with exercise. You have to replenish fluids before exercise, wear a compression, choose exercise wisely. Do not do exercise which I recommend patient, you like walk, you tolerate walk, take a blanket, make a seat, elevate your legs, make a frequent stops. Do not stop what you already doing and you achieve it.
But do it in a way that conditions the body to come back into homeostasis.
It is.
Yes.
And the best part I like about it is that it's actually recoverable. You know, they're astronauts, right?
Yes.
If you in no gravity, after 2 weeks, we develop autonomic dysfunction. So if you see on YouTube or wherever videos, we are strapped to in the space.
Yes.
They strap to treadmill and they continue exercising and being upright and when they come back on Earth, we still exercise. And in the first astronaut in the beginning, we couldn't walk. We actually carry them in stretchers
off of the ships. Yes,
when they come back. So the good part, autonomic dysfunction with POTS, it can be recovered, it can be controlled with medication, with appropriate
lifestyle modifications. And it's almost a reconditioning. I have one little topic that I just want to jump into really quick. Why is this happening post-viral infection? What is going on? So
it's a hard question.
That's a huge question, and that's why. So I know we don't know for sure. But
have another hour?
We will bring you back. I just what are we starting? What are we starting to see? So we're seeing this in long hauler. We're seeing this with viral reactivation.
I forgot very important between genetic and everything. There is autoimmunity possible.
Autoimmune aspect.
The peripheral neuropathy, in a patient with POTS, often also diagnosed with small fiber neuropathy. There is a neurologic condition which your signals is the innervation, the neuros innervation is not working properly. There is some autoimmune conditions which we see in this patient with POTS, like Sjogren's disease. And sometimes treatment of autoimmune condition may be helpful with the POTS symptoms.
Right.
But there is also different researchers in different countries. There is antibody to receptors, to adrenergic receptors. There is identified to antibody to receptors. And because of those antibody, possibly their mechanism is not working in blood vessels and not constricting. There is a lot of different etiologic hypotheses for developing disease. While we looking for hypotheses and resolving this, we have to treat patients. So between one and another, I kind of try to cover everything.
But I just have to say, it's so exciting to have the opportunity to have these kinds of in-depth conversations about a subject like this, because I'm going to say in the real world, right? There's being patient facing, but there's being the patient, right? And in being the patient, and in talking to my women friends and my kids' friends. There's so many people that are getting underdiagnosed or are getting, I understand that there's no biopsy for this. We can't surgicize it. There's not even great labs that
We have a skin biopsy for small fiber neuropathy.
Yes.
We do have autonomic dysfunction laboratory in the major universities, and
but it's really hard.
Tilt table can really be
tilt
assessment.
Table testing. Absolutely.
I'm very stressed to talk about this because I'm saying again, I'm not cardiologist, I'm not neurologist, but I have really good infrastructure with cardiologist gonna do tilt table and neurologist will assist.
We bring a team together.
There
Absolutely.
Is a team.
But in doing that, first of all, we didn't do it just because it sounded like a fun thing to do. We did it because we have to do it in order to get our patients better. We have to have a clinic without walls. We have to be open-minded. And first and foremost, we have to put the patient first. And I don't see that a lot clinically. And so people that are out there that are listening, I want you to know that really, really bright people believe you, and that there is tons of research and data that supports that what you're going through is first and foremost real, but it's also manageable, and a lot of times we can reverse it. And so we want you to have that hope.
We can control it.
Absolutely.
Depending on the factor which causing this illness, but we do control symptoms with patients, and this is cooperation when very helpful when patient really does his part.
Right, but it's critical for people to know.
With appropriate exercise, with appropriate medication,
absolutely,
doing all the measurement. I have really good response when patient, and this is one in the chronic fatigue syndrome world. This is one of the symptoms which I like to address first.
Yes,
and I do see there is a response, and it's really help control whole fatigue world.
Well, it's how the body adapts and how the body regulates. And if we can start supporting that, then the body can start to re-regulate and in a more healthful way adapt. Well, I will just tell you, having a daughter who has friends that are in their 20s that, are super athletic, had to pull out of college because of this, having mom friends of mine that, went through childbirth and labor and raising their kids, and, their 8-year-old, 12, I have an 8, 12, 10-year-old kids, suddenly they can't get out of bed after a viral infection. Being able to be not just diagnosed with this, but really looking at the syndrome and how complex it is, and starting to unravel it, that it's just life-saving and life-affirming. So it's important that we have these conversations, and I'm so grateful that you're here and you're at the Institute, and that everybody in our community has access to you now through these moments of conversation, because it gives people hope and it gives people tips, and it's really, really critical for those that are feeling hopeless right now. So I just can't thank you enough.
I wish I can be more structured, because I feel like we cover many different topics.
But the body's complex.
And possibly didn't even mention all possible.
Of course not.
The factors which can cause these symptoms and this particular syndrome.
Just the decades of education, your wall in your office, and all of your degrees, and all of your degrees, and all of your advanced trainings, and all of your.
I appreciate my colleagues a lot, and to control this illness, we really need input from cardiologists and neurologists.
Absolutely.
And sometimes we do need to recognize there is another reason. It's not a chronic fatigue syndrome, and it's not just regular POTS. It's POTS is symptom of something else. This is important because I do notice it, and then we have to treat diabetes. We have to treat something else because it can cause POTS.
All the comorbidities. But what you just did was massive for those patients like myself that have been out there and have felt lost. And that is that you've given them permission to put together a team of people that study cardiology and neurology and immunology to get them out of the dark place they're in. They don't have to feel like they need to suffer alone, that they need to pull in the data that they've collected by self-reporting effectively and by continuing to ask and ask and ask for care until you receive the care you deserve. Period. So we're fortunate. We have it all that happens within our institute, not only within our clinic walls, but through our research and also through the relationships that we make with physicians across the globe, right? And we do that to find solutions for people that are struggling. So, Dr. Rozenfeld, I cannot thank you enough. Everybody loves you. They want you back on the podcast all the time. I'm going to try and do subjects like this again because it's critical, it's important. And just the fact that you're out there and you're just being such a warrior for wellness means everything to patients like us. So thank you so much.
Thank you so much. Anything to empower a patient and control the knowledge deficit. I love
that. I love that. Thank you. We'll see you again soon.